Okay, so thank you for joining us for tonight's endometriosis update in partnership with St Vincent's Clinic. My name is Bertha and I'm the CPD and Events Manager at Central and Eastern Sydney PHN. I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community and pay respects to elders past, present and emerging. I also extend that respect to Aboriginal colleagues joining us tonight. Okay, on your screen you will see some upcoming events that we are offering. You can use a QR code to view more information or to register for these events. And also, if you need some support from our practice support team, the email is on the screen and they can assist with accreditation, PIP-QI, quality improvement activities, amongst other things.
Thanks very much, Bertha. Good evening, everybody. I'm Katie Viviers. I'm the Chief Executive Officer at St Vincent's Clinic. And I'll echo Bertha's words. Thank you so much for your time this evening. It's lovely to have you joining us for this session. Before I introduce Associate Professor Lamaro, I just wanted to share just a couple of things that are available on the St Vincent's Clinic website, which might be useful resources for each of you. So the clinic website is stvincentsclinic.com.au. And if you click on For Medical Professionals in the top right-hand corner, you'll see what we call our GP referring booklet. And that booklet will give you a really good rundown on each of the 25 plus specialties that are available within the clinic, as well as contact details for our 330 or so specialists, and everything from gynecology to surgical and other physicians in that space as well. So please know that that resource is there, and I'm also very happy to be contacted in the clinic if you need assistance to navigate our website or find an appropriate specialist for your patients. All right, so tonight we're going to be hearing from Associate Professor Vincent Lamaro. Associate Professor Lamaro is a gynaecologist and laparoscopic surgeon, specialising in the management of pain, abnormal bleeding, infertility, and reconstructive urogynecology. With over 17 years of national and international experience across Australia, Europe, and the USA, he has established himself as a leader in the field of laparoscopic gynecology. And tonight, he is going to be talking to us on endometriosis. Over to you, Vince.
Thanks, Katie. Thanks for the introduction. Yeah, so what I wanted to talk about tonight was endometriosis and just looking at a view sort of through your office and through my office. So navigating the different types of issues that we'll see over the patient's ages over time. So navigating the different life stages. Now let's just, here we go. Yeah, so basically we're looking at the adolescents, the patients in their sort of 20s and 30s with severe and acute pain, the fertility issues that we'll see coming through the office, and then the older patients, so menopausal and management of MHT, particularly with an endometriosis or adenomyosis patient, because they've all got some peculiar managements to each group. So the adolescent, understanding the approach to early diagnosis and treatment, pain in the 20s and 30s, understanding when escalation in management is required, infertility and suspected endometriosis, so effective pathways to achieve fertility outcomes in your patient, depending on what they're wanting to achieve, and then menopause, so confidently manage MHT in the setting of adenomyosis and endometriosis with the current evidence. Just in the learning outcomes, because I was asked to give you guys 4 of those. So number 1 would be utilize a simple in-clinic assessment to predict endometriosis with a reliability of over 85%. It's probably higher, but it's just in terms of how to quickly assess in a very simplistic way the likelihood of endometriosis, discuss and implement non-medical and non-surgical interventions for endometriosis management, recommend the most effective pathway to achieve fertility outcomes in your patient, and then just to confidently manage MHT in the setting of adenomyosis and endometriosis. So first little thing, just a few fun slides, but this was the early ancient Greeks' way of treating patients with symptoms of endometriosis and adenomyosis. They called it suffocation of the uterus. So you used to hang the patient upside down. And then in times of Freud, the diagnosis of hysteria, witchcraft, and demonic possession was put forth, and then all of those other historic treatments, uterine suffocation, awful anesthetic procedures on patients. That was Freud's lounge where he used to do hysteria treatment. And in retrospect, and researchers now believe that what Freud was diagnosing as hysteria was really endometriosis and adenomyosis type pain in those female patients. So first patient to really tell us about endometriosis was this guy Rokitansky, who had microscopically assessed and defined endometriosis back in 1860. Then you had the development of the laparoscopes at the turn of the century, 1901. But it was around 60 or 70 years before the laparoscope was readopted. It was very slow to have an adoption because it was put to the back burner. Cameron Neesat in the US designed the first video laparoscope. I'd actually met with him when I was in my early training and his later career. A big unit in America, and then we got down to technology like the Da Vinci robot that gives us, magnification and the ability to do, quite incredible procedures at very high magnification and with great precision. So endometriosis, just to summarize, because everyone knows this, but it's always good in terms of just understanding the process. Endometrial glands and stroma found outside of the uterus. So that's really the definition. So it's ectopic endometrial glands. So it does not involve the uterus. The version that does is adenomyosis. And it's broken down into superficial, deep, and endometrioma type disease. Now, it's important to understand those three because the definition of each of those and the assigning each one to a patient also assigns their outcome for pain, their outcome for fertility achievement, and also possibly their cancer risk, which is quite important. Particularly the last two, deep and endometrioma, have ramifications for long-term management. And the endometriosis obviously grows. You all know this, but it's throughout the pelvis, so bladder, uterus, tubes, ovaries, bowel, upper abdomen, diaphragm, chest, and very, very rare cerebral involvement. Superficial disease. So again, we see these types of patterns. So where there's just tiny little patches of disease that are superficially in the peritoneal layer under 5 millimeters of depth. So you can see here these sort of white lesions, these gunpowder black, and these sort of often missed lesions, which are very hard to see unless you've got good magnification and you've familiar with the disease. Sometimes deep implants look quite superficial initially, and that's why ablation historically has not worked for endometriosis management, either for pain control or for fertility management. So you can't really ablate deep disease. And, this disease down here is an example of the type that just does not respond to ablation because it runs quite deep. And obviously you cannot ablate this type of disease, but this is adenomyosis through the uterus, bilateral endometriomas, rectum being fixed to the uterus. So this is it's a high stage case and quite an aggressive disease. Then you've got ovarian endometriomas. So that's those sort of chocolate cysts which infiltrate the ovary and often bilateral. And they have a particular importance because not only are they significant in terms of pain, but and fertility, but also they have a specific cancer risk on the patient long term. Uterine adenomyosis is a cross-section of the uterus, and you can see here, this is why adenomyosis patients have such significant pain and bleeding. You can see these large venous crypts that are formed with the endometriotic sort of lining. And they basically bleed into that. Every time there's a cycle, there's also hemorrhage into the myometrium. So you've got this significant hemorrhage risk and obviously pain risk and also a cancer risk for that as well. Sometimes they grow to quite big structures. So first of all, how do we look at that in the adolescent? So a young patient comes into your office, and important to understand the risks and the potential flags for that. So early menarche is a flag for early endometriosis. Heavy, shorter cycles because they increase the estrogen exposure and retrograde activity. So be mindful of the patients that arrive in that setting. because they may have an increased ectopic endometrial growth. If there's a first-degree relative, there's up to a 7-fold increase because of a genetic predispositions that young patient might have endometriosis. So if her mother, her sister has endometriosis, there's a high chance that she would have that condition as well. Also, they have an earlier onset and quite a more aggressive disease when there's that family history, because it seems to be a different genetic variant. So the importance to have a high index of suspicion and treat early for those, and generally treat fast because they have a progressive disease. Cervical stenosis, congenital Müllerian abnormalities have a higher chance of retrograde menstruation and hence ectopic endometrial growth. So be alert to the chronic acyclical pelvic pain in the younger ones. So often it may not be cycle-dependent, particularly combined in the young with nausea, dysmen, dyschezia, dysuria, dyspareunia, and cyclical pelvic pain as well. Now, in the office, just a simple assessment to get some confidence at saying, this probably is the disease without, we often don't do laparoscopy to diagnose it. We've diagnosed it before we go to theatres. So pain scoring, so visual analog or numerical, 0 to 10 scoring, and you score the pain for, so dysmenorrhea, intermenstrual pain, dyspareunia, dyschezia, dysuria, and nausea. And if the patient has 3 scores over 5, they've got an 85% chance, when we've reviewed thousands of cases, of having the condition. So you can be pretty accurate with just running that set of questions with your patient. Be mindful that only an abdominal exam or a transabdominal ultrasound might be appropriate in those groups. If you're sending them to the female-specific units, ultrasound care for women, etc., the ladies here are very, very good at working through that with the patients. So, but just be mindful that that's possibly what you might order. MRI can be sometimes used. If it's really important in a young person, we'll do an MRI, but generally that's a tertiary investigation. Pain mediation. So how is pain caused? And again, I'm going to go over some things that a lot of you will know, but I always find it important, even for myself, just to remind us of how it's caused, because then that helps us in the management of it. But so the localized inflammatory signaling, neuroangiogenesis, estrogen-mediated inflammation, and also progesterone resistance in the implants. So the implants have a local estrogen production themselves, and then the fibrosis changes, that contraction of the tissue that you could see in some of those earlier photos, creates pain. There's a complex interaction of inflammatory, hormonal, and neurogenic mechanisms. And so remember, those ectopic endometrial implants that grow outside of the uterus still have a cyclical hormone change, the same as the lining of the uterus change. So there's microhemorrhages, there's edema, cellular breakdown. So there's localized inflammatory signaling. You've got the activity triggers things like interleukin-1 and 6, tumor necrosis factor, and prostaglandin release, which set off the pain pathways. Neuroangiogenesis, the implants produce nerve growth factor and vascular endothelial growth factor. So that's why you see in some of those images that we saw, you've got the vessel growth and nerve growth around the lesions. So you've got this proliferation of neuroangiogenesis, and that sensitizes the local nerves. It increases the density of nerve fibers, particularly sensory and sympathetic nerves, and escalates the signaling. Then you've got the estrogen-mediated inflammation and progesterone resistance, which is specific to endometriotic implants. The cyclical production of estrogen by the ovaries and also the endometriotic tissue itself fuels the inflammatory response, and the progesterone resistance sort of amplifies it's not getting the anti-inflammatory response that progesterone normally gives. So the escalation in pain occurs with that. And then you've got the structural changes. So you've got retraction of tissues, and often, particularly with movement of organs, you've got pain. So when bowel is filling and emptying, when bladder is filling and emptying, when patients are running with intercourse, etc., any movement may set off pain. It's interesting to see that in some patients with very, very severe disease where the pelvis is completely fixed, where there's no movement, paradoxically, sometimes pain scores drop off over time with the extreme severe disease types. So in those adolescents, how do we approach it? So always non-hormonal is number one. So when we've got very young patients coming into the office, they could start with pain at 12, 13. And so you always have the discussion about managing without hormones first. You want to try and optimize all the adjuvant lifestyle things and also some complementary medicines. And it depends, you've got to really decide with the patient and the family together what the best approach is. And even though the guidelines currently say there's no data that shows that things like physio, Chinese medicine, naturopathy, etc. work, I think just the studies have not necessarily looked at that in the correct manner at this stage. And in my practice, we always use, so if patients and their families want to involve those therapies, I think it's important to encourage them because there's always a benefit to be derived from most of those. And I'm sure you've got the same experience. Always trial 3 to 6 cycles or months of whatever treatment you're doing. So in a non-hormonal management, try 3 to 6 cycles and always review until we've got an outcome that's positive. So the sorts of things that are simple and beneficial in the adolescents, so magnesium, there's a blocking of the MDA receptors involved in pain signaling and relaxation of smooth muscles. So magnesium is very simple, effective management. Probiotic, all about gut health, immune function, improved transit time. And so things like less distension of the gut, particularly for patients that have gut symptoms and so-called IBS, they often respond to that. Metamucil for the same reason, motility and transit improvement. Hydration, regulating the inflammatory process in gut transit. So hydration is often underrated, but it's super important for all of this. And also the, things like metamucil and magnesium sort of draw fluid into work. So important to add that. And high intensity exercise studies have shown that doing 3 sessions, 30 to 50 minutes each time, but 30 minutes is enough. Getting heart rate to 80% max 3 times a week decreases pain scores by an average of 2.5 to 3 points on that sort of visual analog score, 0 to 10. So simple, important. It's great, as you know, for lots of other reasons, mental health, etc. Lowers cortisol, endorphin release, and reduces inflammation. So simple to run that. Next step, obviously non-steroidals, again, which again, most of you would do this. Understanding that the data shows that all non-steroidals are effective or may be effective, but there's no benefit to one over the other. So choose something that works. For some reason, some people resonate well with one or the other. So, naproxen, ibuprofen, mefenamic, they inhibit COX-1 and 2, block the prostaglandin cascade and then pain signaling. So that's how they work. And importantly, paracetamol potentiates the activity of the non-steroidals. So I always use them together. So once we get to the time to use these drugs, it's important to use them together. So, gram of paracetamol with the non-steroidals at each event is important. And also some people do alternating, paracetamol and then 4 hours later, non-steroidals. I think it's important to actually use them together because they're synergistic. And remember preemptive use of these. So what we're trying to do is block the release of pain signalers. So if we can stop the prostaglandin cascade from evolving, then we can make that pain score much lower from the very beginning, and then you don't get the day 1, the day 2, day 3 pain explosion that we see in some of these patients. So I always tell them, as soon as you get the absolute hint, if you know the day before or the day of, you start your preemptives and you run them for 24, 48, 72 hours. And generally that's pretty much all they need to do. Now, if that's not effective, obviously you discuss hormonal management. So reinforce that the things that, such as that the data supports the effect of hormonal management. It's very strong data that shows that that's very beneficial in terms of endometriosis pain response. Explain why it works to the patient, because if they understand, they're going to be a lot more likely to have compliance. And the hardest thing with hormones is getting someone to sort of bond with that management without being unhappy or worried about its effect, or what's happening with my fertility, or what's happening with my side effects. So explain why it works. So decreases implant growth and bleeding, prostaglandin suppression, and it decreases the menses volume, which has an anti-inflammatory effect, obviously, as well. Explain the settling in phase. So I always tell patients it's going to take 3 to 4 months before we know how it's going. So in the first 3 or 4 months, always expect some receptor adjustment, expect some minor side effects. They're common, and most people will always get them. And knowing that they're coming is very important in the ability of compliance. How to choose. So obviously shared decision making. Explain that the studies show that now there's no type or modality superior to the other. So it really depends on what the patient, the family have thought. Often they've got some ideas before they come into the office about what they might want to try, but obviously tell them about the data that shows that there's no overall benefit one over the other, and just discuss potential side effects and benefits for choice. Now, the NIC have a good guideline that you can download, which is it's just a algorithm for the patient. It's about 3 or 4 pages for them to look at, and it helps them work through every option. And it's quite a nice thing to be able to give to the patient to help them make their decision rather than putting them on something, day one. What would be my most common approach? So obviously shared decision making. So have that big discussion in the room and it's normally mum and very young daughter. I normally, unless there's a reason, I normally look at a low dose or 30 mcg dose of a combined pill initially. Reason is because there's quicker suppression, but there's also generally less. The data shows that there's less anxiety and depression when you've got a combined pill over a progesterone-only option. But again, discuss it and review it. Discuss with the patient the key things to watch for. It's always in their mind, they might not tell you straight up, but they're always worried about skin, weight, and mood. And so you flag that with them and put it on the table early, and just get them to watch for those things. Now, I often use a pill like levonorgestrel early on because it's got the longest term data. It seems to be surprisingly, with levonorgestrel in it, the best tolerated pill without mood change, although levonorgestrel itself is known to affect mood. But talk to them about watching skin breakouts. I always tell them the importance of understanding that progesterone stimulates appetite. And so when they start a pill, if it's progesterone only or combined, know that they've got to run hungry for a bit, because if they do put on weight, they'll get, they get very down about that, obviously. So, especially for an adolescent, it's a big issue. So tell them to run hungry in the first couple of months, because receptors need to adjust. And then just to watch for mood. Let them know that there might be a early sort of subtle change. Anything that's major, I tell them, my sentence to them is to, if you've got a dark storm cloud that appears on the horizon for you, then we just catch up early and we stop the medication if it's severe, because one in maybe 60, 70 patients have a very severe side effect with pill use within the first few weeks. So just be mindful of that. And always plan review at 3 to 6 months whenever we're setting up an intervention. So what about when we move from the adolescent to adulthood? So we've got those same pain mechanisms at play. We want to ensure, so once we've got that slightly, that late teens, mid-20s, that patient that comes in, we want to make sure that they've got up-to-date imaging. as you know, imaging is different, and not one ultrasound's the same as the other. So make sure we've got a DIE scan done in a centre that's used to doing those, and we want to look for endometriosis and adenomyosis, particularly deep implants or endometrioma, because they're very important in the long-term management. MRI for adenomyosis we sometimes do, might be important, but again, it's probably a tertiary referral management. So when they're in with you, review the diagnosis, ensure that there's no new missed symptoms. So I've had patients referred for endometriosis where we've, diagnosed a chronic ectopic, ovarian, things like torsion, cyst, PID, bowel disease, Crohn's, ulcerative colitis, celiac disease, interstitial cystitis, chronic appendicitis, pelvic floor dysfunction. So all of those things we do see in that cluster of presentations. But generally most of the time you'll have that very long history in your patient, and it'll make sense that this is the only thing that it can be. So you've used your supplementary managements with that, the same patient, and they may not have come in as an adolescent. So this might be their first presentation. As you know, in when we have World Congress every 4 years, the data still shows that it's 7 to 10 years before, complaining about the symptoms to having a diagnosis, still a long time. So this patient may be in their mid-20s when they're coming in for first time, and they've put up with what they thought was normal for quite some time. So you've run your basic managements, you've run through your preemptive non-steroidals, your paracetamol, you've used hormonal therapy. And so sometimes you'll cycle through various options for your pill managements. You might do progesterone onlys. You might, they might want to speak to you about Mirenas. Lots of GP practices place IUDs or implanon. So it's just important to talk to them about what the options are again, and again, review 3 to 6 monthly till we get a response. So at the end of that 3 to 6 months, is it working? Are there significant side effects for your patient? Sometimes if they say, look, I've got some minor side effects, I'm happy to persevere. And I think that's a good sign. And then you just re-review them, and you get them to flag things with you if they're major concerns. Talk to them again about those options. So your progesterone only, your combined pills, IUD options, so low dose, high dose. Vaginal ring there are some patients that actually have great response with that, and also it's a very controllable option, and then the IMI progesterone options. Make sure that they're optimizing complementary medicine, exercise programs, and just listen to the patient in terms of what they're saying to you. So if they're saying that the pill's reasonable, but they've got some other issues, if it's a mental health aspect, if it's a weight gain, is it some very mild skin breakouts? So sometimes you can just navigate the issues if they're quite minor, and we always want to try and have a conservative approach if we can. So at those reviews, just make sure that we're on track, and then once you're more or less on track, then you can see them, probably at 12 months, and then if they're doing great, I just review them every 2 years normally. If it's not working, is it time to refer? So what are the referral cues? So is the pain still significantly affecting quality of life? Intolerable hormonal side effects. So sometimes you just, we try lots of different things and we just can't quite get the side effect profile right. So it might be time to, have us review them for that reason. If they've got an abnormal ultrasound, endometrioma, adenomyosis, or deep endometriosis, always refer for opinion. Important because there's aspects of, as we talked about, cancer risk and also fertility risk outcomes associated with early treatment. So if we can intervene early, that the outcomes are generally better for visible disease. The NICE guidelines sort of state, so don't exclude the possibility of endometriosis, even if the ultrasound and MRI are normal. If you've got a clinical suspicion, and if symptoms persist, consider referral. So that's just an important take-home message. And I think most people do that, but we've got cases where people are running for years without, you know, proper diagnoses, and also they're often not really with one GP, and they've seen a you know, a plethora of GPs, and no one really sort of ends up, you know, taking charge of the care there. So once we see them, can we optimize the medical management that's been set up? So we look at, you know, what they've had, what managements have been, what side effects they've had with various pills, adjuvant treatments for pain, and see if we can add to that. So modify the hormonal treatments, maybe based off the side effects. Sometimes we combine hormonal treatments. So things like progesterone, Mirena with an overlay of progesterone, or Mirena with an overlay of combined pill. Sometimes we need to do several things at once, depending on the side effects. Sometimes they've got a great response to progesterone-only managements with something like a Mirena, but they've got then ovulation pain is the last thing that affects them. And as you know, Mirena doesn't really suppress ovulation. The process keeps rolling. So we've got to try and stop that ovarian event, so that you know, every time there's an ovulation, it's quite a dramatic event if you're looking at it at a microscopic level in the ovary. So if we can suppress that with a pill as well, that might be all we need to do. Then very rarely we need to do things like GnRH managements with ADBAC, or sometimes GnRH with letrozole. They're quite extreme managements. We GnRH and letrozole together, we mostly would use those for severe cases where there's organ effects, so obstructed ureters, bladder invasion, where we're trying to minimize the disease volume significantly before going to theatres, so that we minimize the resection of those areas. So we try and have a preserving option on things like ureters and bladder, of course, and so to shrink the disease before operating is important. There are very rare, like every 2 years there'll be an inoperable patient, so someone who's had so much surgery over time, and maybe many laparotomies, many midline bowel resections, and they're at an untreatable extent in terms of surgery. It's not really appropriate based on the risk benefits and safety profile, and so we've got to manage those patients with GnRH and letrozole. So if abnormal DIE scans or MRIs, so once we're seeing them, they would normally proceed to likely laparoscopy, especially if they're symptomatic. So this is just a first presentation. This is a patient AL that we saw recently. So 32-year-old complaining of long-term pain for more than 15 years. She was placed on ACP for contraception at about age 20, and noticed she had initial pain improvement actually on the pill, which is what she commented herself. She presents to multiple sites over multiple years. Again, she had moved around from ACT and through Brisbane as well, but so had gone to multiple sites with left hip and thigh radiating pain, nausea, dysesthesia, and dyspareunia. Generic ultrasounds over time were always marked down as negative. So, but again, remember the difference between scanning centres that are very good at detecting endometriosis and generic centres, which really, in my experience, are quite poor at looking at endometriosis, and often give a false reassurance. GP referred her into the ED in July, here to St Vincent's in this July, and she had severe acute left thigh, pelvic and loin pain. Physical and labs were all normal according to the doctors in ED. Ultrasound in ED was normal. CT-IVP showed a left distal extrinsic ureteric obstruction and hydronephrosis. So she was managed with urology and with a double J stent. They contacted me regarding her history, and we felt that the most likely cause was endometriosis doing that. The exam showed fixed left uterosacral ligament and rectal nodule. So you could actually feel this if you were sort of looking and thinking about the diagnosis. The tertiary DIE scan did show left uterosacral and rectal disease. And so we placed her on GnRH for 3 months to prepare her for surgery, to try and do conservative surgery for that ureteric disease. So this is just at the beginning of surgery here. So, and this is the right side, so opposite to the obstructed side, but she had the same process developing on the right side as well. It actually looks fairly benign. It's a stent in the ureter just down here that we're moving. And on the left side, stent in here. And this, again, this is a disease after shrinkage with Solidex. And again, looks fairly straightforward. Just over time, we shave out the disease, and it had wrapped around the ureter, hypogastric nerve, and in the side of the rectum there. So we're just slowly over some hours just resecting that carefully, and then by the end of the case, you can see here that this is all cleared out. So you've got a ureter that's completely cleared, running just into the base of the bladder right here. The rectal disease is out on that left-hand side. And so, fairly severe disease, long-term symptoms. Right side was going to be obstructed in, probably within another 12 to 18 months. And we've had patients that present with disease like this where they end up losing renal function. So again, rare, but every couple of years we'll see someone that has silently lost renal function because they've got obstructive ureteric disease. So, our learning points for the team were always circle back to assessments every 3 to 6 months or 12 months and make sure we're reviewing patients with significant disease so that we're ensuring that we've got appropriate response and the patient's got normal quality of life. Listen to your judgment and hear the patient. So, if they're saying they've got pain, well, that's not normal quality of life. So we've got to do something for that. And they're either with you having further treatments and trialing medical management or referrals so that we can see whether we need to change medical management or we need to move to surgical management. Remember, the imaging's often misleading, and also just phone a friend if you're not sure about what's going on. Lots of the GPs just ring us and I'll get a text and flick something back, because often a few simple tests or maybe some ideas on management are pretty easy to share, and sometimes that can save them a couple of extra months of waiting around for treatment. The ESHRA guidelines 22. So clinicians should be aware that there's epidemiological data, mostly on ovarian endometriosis, showing that complete excision of visible disease may reduce the risk of ovarian cancer. So important to remember that guideline. And these have evolved, and they're getting more sort of proactive on surgical management as the guidelines have come out. So when they were around a decade ago, they weren't really, they were very variable on recommending treatments, but we've got a lot more data now on particularly on ovarian cancer risks and fertility outcomes with treatment. Monitoring women with confirmed endometriosis is important. So when you've got these patients, be it adolescent or older patients, just make sure that they're followed up properly and that you're generally, and especially if they're patients that have deferred any surgical treatment that was offered. So if they've had deep endometriosis on the DIE scan, or if they've got endometriomas larger than 3 centimeters, in fact, any endometrioma that's seen on scan, they should be followed carefully with you at least annually to ensure that they've got, the disease isn't progressing, and particularly in the older age group, that they're not getting any atypical appearance in their disease. The guidelines for adjuvant hormonal treatment, again, ESHRA, the NICE, and RANSCOG. So post-surgery, after like that case that we just showed you, post-surgery hormonal treatments have been shown to improve long-term pain response. So important there. They have been shown to, decrease recurrence risk. They've been shown to decrease ovarian endometrioma recurrence, and post-surgery hormonal treatment until conception may decrease inflammatory, biochemical, and immunological events that impair fertility. So reasonably simple. If we can get something that works with the patient after surgery, their long-term improvements are quite important in terms of pain, fertility, and recurrence rates for endometrioma. So, and often we use things like Mirenas after surgery, but sometimes we need to use combined pills if they've got major mid-cycle ovulation pain with their endometriosis. So fertility. Fertility, endometriosis affects up to 50% of women with infertility have endometriosis in retrospective assessments. Mechanisms that impair fertility, so things like chronic inflammation, adhesions, distorted anatomy, compromised oocyte function, endometrial quality, and implantation failure. So they're the sort of cluster of things that result from endometriosis. There's, and again, I don't want to get too heavy into this, but I think it's interesting in the sense of how does it occur at a cellular, biochemical, and immunological level? How does it affect fertility? So at a cellular level, most of the mechanisms affect oocyte and embryo quality. So, and it's been shown that the impact of surgical treatment on the fertility outcomes. So first of all, at a cellular level, you get to reduction in oxidative stress. So endometriosis, the implants generate these reactive oxygen species, ROS, in the ovarian environment, and that damages the oocytes and affects mitochondrial function. So you've got this, the egg quality drops off. Surgery reduces the ROS levels and preserves cellular integrity in the oocytes, so leading to higher quality embryos. So there's lots of research into that, and that's a very important area evolving currently. And there a lot more of the IVF groups are recognizing that, particularly in terms of recurrent implantation failure, etc. Enhanced mitochondrial function, post-surgical reduction of oxidative stress supports mitochondrial functions, which is essential for embryo viability. The biochemical mechanisms, so most of those relate to restoring hormonal and cytokine balance, in all about follicular genesis. So reduction of inflammatory cytokines, the IL-6 and tumor necrosis factor, improve the elevations affect embryo quality, and surgery reduces those inflammatory cytokines. So they create a favorable environment for follicular genesis and embryo development. Normalization of the follicular fluid. So again, you've got these alteration in various factors which will then improve oocyte quality. Immunologically, and that's the one that many people know about, is it has an effect on implantation. So removal of the volume of disease improves implantation success. So you've got a modulation of immune cells. As you know, you've seen patients that have gone off for IVF and they do NK cell sample or T cell subsets. And that's all about looking at this seesawing between the NK cells and the T cells that occurs in endometriosis. So when we remove endometriosis, we improve that balance, and so you've got more effective T cells, and the killer cells drop off. So that and that's really important in the maternal fetal tolerance and the success of implantation. So decreased miscarriage rates, getting back towards normal miscarriage rates, and also obviously and better implantation. Also improved endometrial receptivity. So there's the surgery restores expression of critical markers. So your integrin, your HOXA10. So it promotes the embryo sort of stickiness and adhesion. So you've got that cellular level to improve oocyte quality, you've got biochemical level to improve follicular genesis, and you've got that immunological level, which improves implantation. So they're the things which we can change when we excise the visible disease at time of surgery. So when we look at those guidelines, the ESHRA, the NIC, the RANSCOG, so again, over time, they've evolved in the most recent, particularly the RANSCOG and the NICE, but to some degree, the ESHRA. So operative laparoscopy could be offered as a treatment option for endometriosis associated infertility, stage 1 and 2. So this is a statement from ESHRA, as it improves the rate of ongoing pregnancy. Clinicians may consider operative laparoscopy for treatment of endometrioma associated infertility, as it may increase their chance of natural pregnancy. Also important to weigh up the damage to the ovary, what type of surgery is being planned. Is it cyst stripping? Is it ablation? And so important to know, and what's the egg reserve, what's the AMH in those patients. Operative laparoscopy for deep endometriosis improves fertility. Operative laparoscopy may represent treatment option in symptomatic patients wishing to conceive. So if you've got a patient who has classic cyclical pain, which they're the group that we mostly see from the IVF groups, are patients that have declared their pain over time, and sometimes it escalates with treatment. That flags the need for treatment on those patients, because they'll have often an improvement in their IVF success. Again, the guidelines also say management of endometriosis related to subfertility should have a multidisciplinary team, involvement with input from a fertility specialist with access to services and endometriosis surgery. So that's an important thing, that we work together with the groups that provide assisted fertility to look at the best approach for each patient. And there's many, many different issues which occur, which need to be thought through with the specialists, and we'll often have discussions over time. We might look at, they may have had a couple of failed cycles, then we look at whether they may have endometriosis based on pain scoring exam, DIE scans. Sometimes we're doing surgery before IVF, sometimes we're doing it after cryopreservation to improve the environment prior to replacing an embryo. Some of them are just egg freezing, and so sometimes we want to they'll harvest and cryopreserve, because as you can imagine, the environment in the patient is, if you like, at its worst after full stimulation for IVF, where they've had lots of, if you look in an IVF patient just after stimulation, the ovaries are massive. It's very inflammatory. There's a lot of free fluid, inflammatory exudate around. So an IVF patient has that multiplied. So their disease is active, plus their ovarian activity, and the estrogenic environment it escalates that hostile environment, so that we want to almost get it as bad as it can be before we treat it. And hence they do cryopreservation for a couple of months, and then we'll transfer an embryo. And sometimes, particularly in patients that have had very poor response to embryo transfers, and this sort of unexplained loss of healthy embryos, it's very important to, if we think endometriosis is in the background, to treat that prior to proceeding with fertility management. So this is a patient case study, IW, 38-year-old lady, primary infertility of 7 years. So she tried naturally for 4 years, and then IVF for 3 years, and again moved between ACT and Sydney with her IVF managements. She was referred, she had made an appointment with a new IVF specialist here, and then they referred her prior to any treatment with the possibility of endometriosis based on her fertility history. She had a pain history with Dismen score of 4, dyschezia 7. She had menstrual diarrhea, and she had this very long history of so-called IBS, which again, many of you would have seen with patients where their predominant symptom of endometriosis is bowel upset. So if long history of IBS, just suspect that there might be something going on. The exam was positive, query endometriosis, and her DIE scan did show an endometrioma and deep bowel endometriosis. And this, in fact, was her surgery. So she's got this vesicular, it was actually a little bit worrying at the time, but vesicular disease. It was not malignant. There was erosion coming out of the adenomyosis at the back of the uterus. The rectum is fixed to the uterus, endometrioma on that left ovary, adherent to the ureter on that left side, and the rectum. And management of this is essentially just over time we shave all of that disease out and our target for her is to try and achieve actually a natural pregnancy, because she's still in that age group where she may get an excellent result from just surgery alone. And we generally would, as long as we've got removal, that's just the ureteric stent moving on that side, but as long as we've got removal of all visible disease, which we did in her case. So by the end of surgery, you can see here all the disease has been removed. Our rectal disease is removed, bilateral ovarian and ureteric disease removed. So as long as we can remove it to its visible sort of normality, we would generally, and all other factors fine, normal male factor, triple patency, normal cavity, then we want those patients to try for 4 to 6 cycles of natural, as long as they're in the right age bracket. So she'll probably try for 2 or 3, she's 38, and then she'll move through IVF if needed after that. So our learning points for her were, always question long-term unexplained infertility. Remember, they may have no symptoms and a normal ultrasound. So don't exclude the diagnosis, but think about unexplained infertility, recurrent miscarriage, recurrent embryo transfer failure. We want to think about the diagnosis. So, and think about the diagnosis of endo when you hear of a patient having years of IBS symptoms, because remember, IBS is a diagnosis of exclusion. So we haven't excluded endometriosis, which in young women with IBS, most commonly it relates to endometriosis. Careful history examination and imaging often tells us a story. So with this patient, if we sit down and we really have a chat about her history from menarche to the time that she's been trying to conceive, often it's quite obvious what the issue is. And ensure that when your patient, you're steering your patient through their treatments and their fertility journey as well. So make sure that whoever you send them to has the available, all available managements. So make sure that they work together with fertility specialists and endometriosis specialists, and often they're one in the same. Sometimes, I do a lot of work with IVF specialists. I don't do IVF myself, but I will work with people that do a lot of that through groups like Gynaecologist, Australia IVF, Monash, and there are some great specialists in all of those groups that have a good understanding of endometriosis and its the current data supporting management in certain patients. Then we've got the older patient. So the menopausal patient, there are some important sort of aspects to endometriosis management and MHT management in this group. So patients with a history of endometriosis and or adenomyosis warrant specific attention to their MHT chosen and appropriate long-term screening to avoid increasing malignancy risk. So really important, if you've got a patient who you're looking after and they're coming into menopause, or they are menopausal, or they're post, we've got to think about the two big things are, if we're going to be thinking about MHT, how do we manage it without increasing other risks and aggravating symptoms? So not just malignancy risk, but aggravating symptoms of pain or abnormal bleeding. And also, if we're not using MHT in this group of patients, how do we keep an eye on them? How do we screen them? So it's very important with, particularly with patients with deep disease or endometrioma, and even if it's historically treated, that they're watched long term because their cancer rates are higher. Again, most of you know this, but ovarian cancer in endometrioma and deep endometriosis patients, there's a 2 to 4 time higher risk of developing ovarian cancer through the lifetime. It's predominantly linked to endometrioid and clear cell cancer subtypes. The mechanism is, this chronic inflammatory process, oxidative stress, which we talked about in those earlier slides. And there are genetic mutations in some variants of endometriosis in the lesions, which put them at high risk. There is a slight increased risk of endometrial cancer in these patients because endometriosis implants have a local estrogen production process themselves. So there's a sort of an extra estrogenic influence over quite some years in these patients. And there is a slight increased risk of breast cancer in these patients as well. So important when we're looking at those patients to make sure that we're screening them. We're looking at their ovaries, we're looking at their endometrium, we're looking at making sure that they're up to date with their breast screening. And that's something, you know, I generally, once we've got things stabilized in the menopause, I think at the very least a 2-yearly assessment is quite reasonable in those patients. Now there's mixed data obviously on general rolling out routine ultrasounds for ovarian cancer screening, but we're not doing that. We're screening a group that is at higher risk, and I think it's important to know that, especially if they're on treatments, that we're not aggravating endometrium with endometrial thickness, and that we're not promoting endometrioma development or size increase, and we only can see that by looking with scan. So important with your patient, check. So how severe was their endometriosis historically? So if they've just come to you and they're in their perimenopause and you don't know the history, just talk to them about how severe that history was for them. Did they have deep disease? Did they have endometriomas? When you are evaluating them, is there visible disease on imaging? If there's visible disease, they're an important group to refer or to discuss how best to watch them. Consider ovarian surveillance for deep endometriosis or endometriomas, and also consider obviously ovarian and uterine surveillance if we're using MHT with that history, because they are at increased risk. Really important one, and we're doing a paper at the moment on, because it's still, even though it's talked about in the guidelines and there is, you know, reasonable amount in the literature, it's still poorly done. But a hysterectomized endometriosis patient needs to be treated as if they have a uterus. So, and what I mean by that is, so if you see a patient, they've had their uterus removed, but they've got a history of endometriosis. So most patients will, if they're on HRT, MHT, they'll be placed on estrogen alone because they don't have a uterus. And we see this every week, and we see it from many specialists. Many gynecologists still put patients on estrogen alone management, and it's still poorly managed, I think, worldwide. The guidelines really stress the fact that unopposed estrogen in an endometriosis patient really shouldn't be used. So treat a hysterectomized patient as if they have a uterus. Those implants are under an estrogenic stimulus. So if you just put them on unopposed estrogen, effectively over time you will have a much higher chance of developing a cancer, just like you will if you put a lady with a uterus on unopposed estrogen. The ESHRA guidelines, so avoid prescribing estrogen-only regimens for treatment of vasomotor symptoms in postmenopausal women with a history of endometriosis, as they do have a higher risk of malignant transformation. Really important message. Adenomyosis. So again, there's that slide of that cross-section. So remember, if you put a patient with a history of adenomyosis on MHT, you're going to aggravate implant growth and implant development. And so you're likely to create escalation in pain and bleeding. A patient with a history of severe endometriosis. So the guidelines do support use of MHT in a patient with history of even significant endometriosis, but you want to make sure that's shorter duration. So guidelines suggest if they've had that history, generally use it up till the age of menopause plus 5 years. So consider shorter duration and maybe a higher progesterone to estrogen ratio. So remember, you don't want to drive the implant regrowth. A patient with visible disease on imaging or symptoms when you're considering MHT really probably requires surgery before commencement. Generally speaking, you wouldn't run MHT in a patient with endometriomas without consideration of management of those. But ideally, we would talk through that with that patient and see if we can have them on no treatment, observe the ovaries and watch. And often those, if the endometriomas are under 3 centimeters, they'll probably regress in many cases without estrogen. What does ESHRA say? So clinicians should be aware that there's epidemiological data mostly on ovarian endometriosis, showing that complete excision of the visible endometriosis may reduce the risk of ovarian cancer. So that's important to let these patients know that if they've got visible disease, they've come into you, they're either 1 MHT or they don't, but that you've had a screening assessment. If they've got visible disease at that age, it may be important to treat at that stage as well, particularly if they're symptomatic, because menopausal women, even not on HRT, can be symptomatic, and they are a higher risk group. So the guidelines also state, so ovarian cancer risk may be elevated with prolonged use of estrogen-only MHT, so important message, particularly following surgical menopause. So following early removal, you'll have patients who've had a clearance of uterus, tubes, ovaries in their early 40s for severe endometriosis, and then put on estrogen alone therapy. That is an absolute contraindication. So they've got to be put on combined treatment, and we run combined treatment till the expected age of menopause, due to the benefits of MHT, in terms of dementia and cardiovascular benefits, if we've put them into an early menopause. But we don't generally run it longer than that. Combined HRT is preferred to mitigate the risks, but the guidelines say that it still has a slight increased risk in ovarian cancer. So in an ideal situation, you would talk to your patient and perhaps try to encourage them to move through their symptoms using different strategies that are not hormone-based. And evidence suggests that tailored HRT regimens and careful monitoring are critical for women with an endometriosis history. So we need to watch that group long term. If imaging or symptoms become an issue, refer for review. Important take-home point. So in summary, with our adolescents in endometriosis, suspect if, with an early menarche and a family history and they're coming into you with pain, just suspect that endometriosis is a diagnosis, and have that very early suspicion. Treat early, but always avoid surgery in the young patient. Non-hormonal always first, and hormonal options to be discussed as we mentioned. And then always review at that 3 to 6 month mark, and just circle back to reviews until we get a normal quality of life. Then in that slightly older patient, non-hormonal and hormonal options, of course, again, always ensure that we've got adequate imaging and a proper DIE scan. We want to know about endometrioma. We want to know about deep invasive disease, because they have implications for, worsening of pain, infertility, and also increased cancer risk. Always circle back, review it 3 to 6 months until we've got normal quality of life, and then set up a follow-up schedule for them so that you're just watching them over time and see what their needs are. Is their pain under control? Over time, do they have fertility objectives? And longer term, obviously the MHT question. If they're not responding to medical treatment or significant side effects, consider referral. If ovarian and deep endometriosis, complete excision of visible endometriosis may reduce the risk of cancer. So important with those patients with major disease that they do get referred and get treated. And then the fertility group, summary for them: surgery to achieve natural pregnancy with stage 1 and 2 disease. Deep disease or endometrioma is often effective at improving their conception rates, and particularly if anyone wants natural conception, spontaneous conception options, important to treat disease to improve their chances, particularly if they're in the group that's under sort of 37 or 38. Natural pregnancy rates are significantly higher in that group. An MDT approach is important when you've got an infertility patient. So make sure that you've got groups of people that work with you. So you've got the fertility specialist and endometriosis surgeon, so that the patients can have not only all the options, but the best options, so that whether there's a need to think about progressing to fertility management first, egg collections first, cryopreservation. But if endometriosis is suspected, the data is really evolving that treatment of the disease should be carried out before fertility management, and certainly in that younger group, the outcome of spontaneous pregnancies are higher. And then in the older patient, remember ovarian cancer is elevated in patients with deep disease and endometrioma. So consider when they're seeing you, just make sure that you plug them into a bit of surveillance. So make sure that they're seeing you every year or two, that they've got appropriate follow-up. If they're symptomatic, you tell them to flag it with you earlier and make sure that ovaries are not showing endometrioma growth on scanning. Always avoid unopposed estrogen in an endometriosis patient post-hysterectomy, and treat the implants like they are uteri. So that's just the simple message there. And with MHT, less is more, but sometimes consider more progestin. So sometimes if you are going to run it in those patients that have got, especially, history of significant disease, you don't want to aggravate symptoms, and sometimes you need to use a little bit more progestogenic management in that group to avoid developing side effects. Thank you. So I'd open to any questions if anyone has any questions regarding the 4 groups.
Yes, thank you, Dr. Professor Lamaro, I should say. We've had quite a few questions. It's been excellent and comprehensive talk. One of them is, you mentioned ovarian torsion as one of the DDs that we shouldn't miss. How do you diagnose this, as it's impossible to get a timely ultrasound when they present, which is usually 5 p.m. and usually a 5 if it's a Murphy's Law?
Yeah. So look, ovarian torsion. And in fact, we had a case last night of a fibroid torsion and she'd just come into Sydney. The fellows saw her, and the imaging, unfortunately, our imaging here at St Vincent's, had determined it was an ovarian cancer. So we got her over to the Royal last night. She had treatment last night. It ended up being a torted fibroid, but they present in very similar ways. So they've got essentially acute abdomen, acute nausea and vomiting, and an ovarian mass. Now, if you can't get I think really as a GP, if you see a patient that comes in and they've got acute onset of pain and vomiting together, it's a classic sign. They almost double up. Imagine testicular torsion, exactly the same mechanism. So they double up and they throw up. And if you've got that, you can almost know that that's torsion, but you'll send them into an ED. High index of suspicion. Our ED here has 24/7 imaging if it's needed for ectopics or torsion, so that can be arranged. But you want to and have a good line to your favorite O&G or who work in a setting like we do here, where you can contact us or our fellows and get some advice. People can ring the hospital, switch put them through if you're not sure about the diagnosis, or if you're ringing us, or a lot of you guys have my mobile, you'll flick me a text. But we can often get an imaging done within an hour or two of that patient hitting the place. So it's not hard to do, but if you can't get that ultrasound, and it is really difficult, then you just flag it with us, send them in here, and we'll need to do it here, and often it happens pretty quickly. But double up in pain, nausea and vomiting, classically they might be. You might have known that they've got a dermoid, or they've got some sort of chronic luteal cyst or something like that, but often you don't know the background, just that acuteness, and occasionally it comes on with things like intercourse because it's been mobilized at that time. So they're the things to think about.
No, thank you. Now I've got a good question here. Does the Mirena work for suppressing endometriosis? Because they commented, I would have thought that it was not sufficient to suppress the pituitary ovarian cycling of the ectopic endometrium.
Yeah, so Mirena has actually been shown to be actually quite effective. It's not the one thing it's not good at is suppressing ovarian, so ovulatory pain, but it does have a suppressive effect on implant growth, and also particularly on any adenomyotic activity in the uterus. But it's a very effective local pelvic treatment for implant suppression, and again, the data shows that there's no benefit from using Mirena to progesterone-only pill to continuous pill in that sort of implant setting. There is certainly benefits for certain things, such as, if they've got estrogen side effects, if they need suppression of ovulation in the ovary, we've got to move the hormonal treatment around. But whether we use Mirena, Implanon, pill, progesterone only combined, the results, the data shows the results are the same. It just depends on, it's more their side effect profile, I think, that determines what we use there.
Oh, thank you. And someone's mentioned that he thought that estrogen could potentially worsen endometriosis or lead to its spread and growth.
Yeah.
There seems to be a shift now to using progesterone-only options when it comes to hormonal treatments with endometriosis. Would you agree with that, or could you provide a bit more insight into
that? And look, we used to always, in our early teaching, it was always thought that putting them on a pill was almost it would complicate the condition because you are giving them estrogen. But if you sort of look at that curve of estrogen peak and trough over a menstrual cycle, the estrogen that you're providing with the continuous pill management, it actually decreases their estrogen burden. So when you're looking at the estrogen effect on endometriosis, pill use actually decreases the estrogen burden. So progesterone-only management, as much as we would think it would be more effective, is not necessarily more effective. There are certainly some cases where we need high progesterogenic management to suppress certain types of activity. And it is more profound for certain things like some of the bleeding aspects of adenomyosis. Sometimes there's a benefit to using it there, but the overall burden of estrogen is decreased when they're on a combined pill rather than nothing. Thinking about adding it to think about using progesterone management alone or progestins alone. There are some cases where we would do that, more adenomyosis or and sometimes even fibroid endometriosis patients. There's certain conditions where we would favour progesterone only management, and obviously migraine patients with visual aura, etc. There's other groups that need that, but there doesn't seem to be a benefit to one over the other in terms of implant progression.
Oh, thank you. That probably leads into the next question, which is someone's asked, what about the use of Gynaecologist or Vincent, which is the progesterone just by itself? Is that more or less effective than the progesterone only or the combined pills? And does it have less side effects or more side effects as well?
So in my experience with that is we would normally use it more short term. The side effects on Vincent generally seem to be more profound over time, and so I rarely, it's a medication I rarely use, and I would normally use progesterone only or combined managements without drugs such as Vincent because they are more profound and more side effect promoting, and I'm not sure if we get a quicker result. We probably do to some degree, but I think 3 to 6 months, generally, very occasionally 12 months. If someone comes to me and they're already on it and they're managing well, and there are some patients that seem to just have a good response and like it, tolerate it, don't have much in the way of side effects, well, I think it's reasonable to do that. You've got to watch, bone density, and you've got to watch side effect profile. And sometimes they get significant sort of local, vaginal irritation and dryness and some contact bleeding from the cervix from being on high dose progestins like that. So just things to watch for.
Oh, no, thank you. Someone's written about if you have a young patient with a chocolate cyst on the transvaginal ultrasound, would the progesterones be enough, or the pill be enough, I guess, or do they usually require more treatment?
Yeah. So how old?
Oh, I think they were just talking, came through during that young adult sort of.
Oh, yeah. Okay. So, look, I think so. First of all, are they symptomatic? If they're symptomatic and they've got a chocolate cyst, I think it's worth review with us. However, it's certainly not, if they're only mildly symptomatic, it's not harmful to watch them over some time. So, and because sometimes progesterone only management will sort of settle that endometrioma down. If it's small, like if it's 1, 2, 3 centimeters, then I think it's reasonable to watch that. If someone comes in and they've got significant symptoms in a 4, 5, 6 centimeter endometrioma, they'll nearly always need treatment, and early treatment sometimes in those patients that are symptomatic with very visible disease is a better outcome then, and also putting them on suppression after that. And for endometriomas, I generally put them on combined, if I can, I put them on combined suppression after surgery, because that seems to be better from an endometrioma recurrence point of view.
Thank you. Got an interesting question. Does adenomyosis have a similar impact to endometriosis on oocytes?
No, no. So it doesn't. So that inflammatory milieu is not really present in the pelvic. So if they've got pure adenomyosis, now I'd say that pure adeno is very rare, but we see it occasionally. So most of the time, like that's the image that we saw with the significant endometriosis in the patient that presented for fertility management. You've got adenomyosis, that was that vesicular disease, and you've got severe endometriosis. They normally go hand in hand, but occasionally we see pure adeno with 1 or 2 spots of endo, and it doesn't seem to impact on their fertility as it does with severe endo without adeno. So, but most of the time, it's very rare to find adeno alone without endometriosis. Just as it's very rare to find for a patient to have an endometrioma with no other widespread disease. That in my experience, I reckon I've seen 2 or 3 cases where we've been surprised where it was an endometrioma, it was mobile, and it was isolated in thousands of cases. I think that's very unusual.
Well, thank you. And this probably overlaps a little bit in young adult women who aren't trying to conceive. When do you do the laparoscopy sort of thing rather than, I guess, presume the other treatment?
So if they're not trying to conceive and they've got pain?
I presume they're symptomatic, yeah, to be sure.
Yeah. So look, if they're symptomatic and they're not trying to conceive, I'll always work through medical management if they're happy and comfortable doing that. And so it's about that dialogue with the patient. If they're really happy to try and manage their symptoms, and some of them even want to use non-hormonal management. But again, we step through that non-hormonal, hormonal, and surgery, depending on how successful we are, and then it's up to the patient. But if we've got some patients that come in who don't want to be on any hormonal management at all, very adamant, they want to go straight to surgery, and I think that's reasonable. You still do have to talk to them about adjuvant medical management afterwards, that it does give some benefits. And I think once you have a good discussion with them, most patients, when we say, look, we might put, say, a Mirena or even a Kyleena if they're worried about side effects in at the end of surgery to just give us some benefit to regrowth and suppression. But importantly, we'll review you. If you want it out at any stage, we just take it out in the office. But the best time to put a Mirena in is at time of surgery. So have that discussion, but we've got plenty of patients that still don't want to have hormones in their body, they want to have surgery, and they don't want to do anything else, and they may need a couple of surgeries in their sort of 20 to 50 windows. So if that's the case, I think that's fine as well. I think having a couple of laparoscopies over that time is reasonable if they don't want to be on years and years of hormonal treatments, and then you just watch them and make sure that they don't have any major symptoms and that they don't develop any visible deep disease or endometrioma.
Thank you. And you mentioned about oxidative stress and also complementary medications. We've got a question about the use of NAC, which is N-acetylcysteine, I assume, and turmeric. And it just says NAC, which is antioxidant, has papers that says it reduces ovarian endometriosis and improves fertility. And there's some papers on turmeric or curcumin in endometriosis.
Yeah. So look, NAC is used. So there's a lot of, or not a lot, there's a few leading IVF specialists that are it's a very important part of their management, running things like NAC for embryo quality and for endometriosis management, and often it's for embryo quality outside of endometriosis. So there's good data on NAC. I don't know. I haven't read the papers on turmeric. I don't know, but there's certainly no downside. And if we've got patients that follow an anti-inflammatory diet, I think that's it's never negative. There's no downside to doing that. It's not like, say, if they're overdosing on omegas and fish oil and they've got bleeding risks and they're having anemia with adenomyosis bleeding. Well, we get them off that, but there's no negative issues with an anti-inflammatory diet in terms of turmeric and some of those things. And there's good data on NAC, and it's the benefit on embryo development. On egg quality.
Is there a dose you can think of the top of your head?
No, 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 there's not. So they always come to me on NAC. So I must say, the two big groups from Australia IVF and Monash, the patients by the time they come to me are on a range of supplements, and NAC's one of them. But I don't know dose for that.
Yeah. And I've got a good question. Is endometriosis associated with an increased risk of autoimmune disease? The doctor asked me had a patient who had endometriosis and years later developed lupus.
Yeah, look, they always talked about it being in a cluster of immune dysfunction conditions. So I don't think we see higher incidences of autoimmune disease as such. There might be a slightly higher incidence of thyroid disease, which is I think there's good data on that. But in terms of lupus, I don't think there's a link. There was a theory, and I think it's still reasonable, that there's almost a sort of a semi-blindness, immune sort of blindness to endometriosis, but there's an immune response, and then there's a failure of the immune response. So if they have a total immune response to implants, a lot of patients that are born with endometriotic implants destroy them over their time. So very quickly their immune system recognizes and they have complete destruction. And so there's no disease. Then there are some patients that have complete an immune sort of blindness to the disease, and they don't experience any pain symptoms. But if you were to put a laparoscope in, you'll see very active disease. Then there's the group that suffer a lot of pain, and that's because there's this constant immune response to that chronic condition. And so there is some thought that there is an immune deficiency to some degree in them dealing with their disease, but it's not reflected in widespread conditions like lupus. And so I think they're a separate group of conditions, but thyroid disease is one that flags as a definite high risk longer term. And so we watch for thyroid disease in most of those patients as well.
That's interesting. And should all women with dysmenorrhea have a DIE scan, a detailed endometriosis scan?
I don't. If they are not responding to treatments, I think it's important. But by the time most patients have got to me and their GPs have worked them up, I normally make sure that they've got one very good scan done at one of the centres. There are two or three. There's Ultrasound Care for Women, Sydney Ultrasound for Women, and Omni. I think those three groups do very good scanning and very good reports. And as long as they've had a good scan, it generally doesn't influence what I do. So, but I think in long-term surveillance, sometimes it's important if you've got conditions that you want to exclude, or if a patient doesn't want to have surgical intervention, but they've got significant symptoms. Well, we want to know that they've not got colorectal, ureteric, or endometrioma disease, because they do have long-term implications. And as you saw with a ureteric patient, you can have obstructive disease, which is actually very silent in terms of kidney obstruction. And the patients that we've seen that have had needed nephrectomy because they've lost their kidney renal function on one side, they've not had a lot of symptoms. They've had pain, but manageable, but people haven't been watching. So I think DIE for them is important. Sometimes for fertility is important if you're not sure, but it depends if it's going to change your management. And so if a patient has significant symptoms and is looking at laparoscopy, if I've had a detailed scan, I generally don't do a DIE. They're a bit more invasive, they're a bit more expensive, but they are a good test, and certainly in the general practice setting, I think a reasonable thing, if you're sitting on a patient and looking after them and making sure that that we're not missing anything important, I think a DIE scan might be a good thing in that patient, because they're going to be with you and they may not need anything more than that, and you've got the confidence then that they don't have those deep implants or endometriomas or things that might need to be flagged.
Thank you. Someone's mentioned is interested in your opinion on the study that suggested a link with Fusobacterium and endometriosis.
Oh, I don't know about that.
Haven't heard of that.
No, sorry.
Whoever asked that, if you might want to
Yeah, look, if you
Professor Lamaro.
Yeah, flick me an email, and I'll have a look at it and get you some information back.
No, thank you. And can hysterectomy be used be the last resort treatment for endometriosis. I had a patient who was adamant that she needed hysterectomy to treat her condition. She couldn't tolerate IUD or other hormones, and she had surgical resection previously to treat endometriosis. However, she was still in a lot of pain when she had periods.
Yeah. So, and that's a common story actually. So there's a few things at play there. So the first thing is, you know, who has looked after her, who's resected her endometriosis. And the problem we have now is that there's a lot of ONGs out there that do parts of, you know, they might do ablative therapy. We're still seeing people that have diathermy to implants, and you cannot diathermy deep endometriosis with any effect. And in fact, it's not really safe to do that, especially if it's in bowel or ureteric areas, etc. So did they have a complete resection? What did the images or the pathology say once they'd had surgery? So if they've had an optimal procedure by someone who is reputable, does a lot of that, then I think the next step is to question whether there's adenomyosis. And again, in my experience, most of the time with patients where you've moved right through the solutions and their hormonal treatments, and they've had ideal resections, and they've still got significant symptoms and they can't tolerate IUD, they do have adenomyosis. And again, in my experience with most of those, by the time they get to the point of hysterectomy, they do have a good response. But it's important to note that at time of hysterectomy, you've got to make sure that you assess fully for endometriosis and deep disease again, because you cannot leave endometriosis in a hysterectomy patient. If you do, their pain's much harder to manage, because imagine when you take the uterus out, you're sort of closing the vaginal cuff and you're locking in areas of disease, which can be very, very difficult to get to in the future. You're always doing ovarian, or nearly always doing ovarian sparing surgery in those patients. So they're going to have ovarian production and estrogen production, which will stimulate implants if you leave them. So, because the data shows that patients that have just hysterectomy without endometriosis being addressed do far worse than patients that don't have hysterectomy.
Mm.
So important to just make that assessment. But treatment in that group with removal is often beneficial because it's adenomyosis, and sometimes we'll do DIE or more commonly MRI to try and help us work out what's going on with the patient before we do anything. For patients where they're not sure whether hysterectomy is going to benefit them, we do, say, 2 or 3 months of Zoladex suppression. So we'll put them in like a fake menopause, and they can see how their symptoms are in that environment. And often they're helpful things which allow us to make a confident, prediction that they'll have a good response with uterine removal.
No, thank you. That makes sense. And someone has a young female patient with suspected endometriosis, pelvic period pain, wants to know if Implanon helps, just like Marina does in the other patients.
Yeah. And did you say she was young?
Yeah, young female with suspected endometriosis.
Yeah. So look, Implanon, again, they all work as well as each other. My experience with Implanon is that there's a lot more breakthrough bleeding and symptoms which the patients don't particularly like. So Implanon for me in my practice is not something that I use, but there are a lot of practices out there. There are some great GP practices in our area here that run very large volume of Implanon insertion processes. And so I think it's a reasonable and often effective management, definitely an option to use, and sometimes really convenient for a patient. And so I think it's fine to try it, but just the biggest issues would be nuisance breakthrough bleeding would be the number one for Implanon as an issue. So just to watch for that.
And what about the new drug, like other drugs as well, and also Ryeco?
Yeah.
How do you pronounce that?
Yeah.
Is that something GPs can prescribe for endometriosis? And when would you advise that to use that?
Yeah.
Look,
Look, I think by the time you get to Ryeco, you're having the patient referred. So essentially we've been utilizing, so long before, so Ryeco, as you know, it's a GnRH analog, and it's an estrogen replacement and a progestin. So it's a combination of estradiol and norethisterone and GnRH. And the reason why the estrogen and progesterone are there are to offset the the bone density effects of GnRH. So it is that there's some reasonable data on it. I'm not fully convinced at the moment on we use GnRH without add back prior to certain treatments or for sort of a pulse of treatment for 3 months, but we don't generally run. We certainly never run long-term GnRH longer than say 3, 4, 5 months because of the bone effects. And generally, we're using it to achieve a result before surgery. We're shrinking fibroids, we're shrinking adenomyosis. If it's in a very enlarged uterus and we want to get to a keyhole option, we're shrinking down disease around ureters and bowel so that we can have safer outcome and no complication rates with ureteric or bowel injuries. And so, but as a management, I think if you're thinking about something like Rayco, I think you would have them referred first. There may be again evolving data that show that there's no benefit over other hormonal treatments, which are not as side effect producing as those. But and also at the moment, as you know, it hasn't got it's an expensive drug as well. So there are a few reasons for maybe holding off on it, but I think it's probably not a just like letrozole management. I don't think you would get to that stage in general practice generally, but if it's if your experience is very extensive in terms of medical management of endometriosis in general practice setting, it may be an option to look at that, or even just discuss it with your favorite O&G who manages endo, and just say, well, what do you think about this, and could I run it and review it at 3, 4, 5 months. Side effects might be an issue. That's probably the most common issue on it at the moment, and it's more the norethindrone because it's a decent dose, so a lot more of them are getting norethindrone side effects, but something to watch for.
And the last question is: older women with symptomatic endometriosis close to the menopause, Depo and Provera injection short term, does it help control the symptoms, and how long would you use it for?
So an older woman
An older woman,
Yep.
symptomatic with endometriosis closer to the menopause, could you use Depo?
Oh yeah, look, I think I don't do that. I would use something more oral or Mirenas or I don't use Depo in an older patient, but there's probably no reason not to. You've just got to think about bone density probably in that group. But as a short-term option, maybe I think because of the impending sort of timing of menopause, it's a bit harder to watch what they're, hormonally what they're doing. So sometimes, for instance, if we use Mirenas in those patients, we can still watch what their hormonal production is in the background there's no real effect of the Mirena on those blood results. So we can tell when they're peri and when they're menopausal, even if they're amenorrheic, but it's a bit harder with Depo. So then you're running it longer, and then you've got in that older age group too, you've got, bone effects and certain other effects that might not be ideal. But there's certainly no hard and fast rule on Depo in that group. And it might be reasonable, but it's not something that I do.
No, thank you, Professor Lamaro. And Bertha's been able to find the paper. There's a paper in PubMed just about fusobacterium and endometriosis and endometrium, but we'll send it to you.
Yeah, do you want to shoot that through to me, and I'll have a look at that.
Whoever's asked that, please make sure that Bertha and Lydia know who it is, so we can actually give you some feedback as well about that. I just looked it up and just said 64% of patients with endometriosis are positive for fusobacterium in the endometrium, and I think it's something to do with it's a theory, I guess.
Yeah. And what's the year of that paper?
Oh, I don't know. I've just got it on my phone.
Oh, okay.
It's a PubMed one.
There was some theories floating around, and it was was when I was training, there was a big push that there was an infective agent behind endometriosis escalation symptoms. So, and then there was there was a thought that chlamydia and would activate endometriotic growth, and so it ran for about 5 years. So it just depends on. I haven't seen that paper. It'd be great to read it, but if if it's very recent, be really, I think it's
2023
important.
in science, I've got one
Yeah.
that came up. So,
So important to have a look at that. But there have been from time to time theories where they've thought that bacteria sort of sets off the cascade, and there might be. I haven't looked at that paper, but there might be some important information on that.
yeah, no, look, thank you very much. Look, that's been an excellent and very comprehensive talk, Professor Lamaro, and thank you everyone for their excellent questions as well.
Yeah, good questions.
It's been very helpful, and it's a very there's a lot of increased press about endometriosis, and so a lot of patients are more aware about it now.
Yeah, and there's a lot more
biggest thing.
information, but I would say, like, take-home messages too. Look at the guidelines. So there's some really good information on the ESHRA, NIC, and the RANSCOG guidelines, and there's some very helpful handouts for the patients that you can download from those sites that are helpful, particularly the NICE sites, which make management a little bit easier.
No, thank you very much.
Thanks very much. Thanks, guys.
I'll jump in. Thank you so much, Janine, for facilitating the questions today. And thank you, Associate Professor Lamaro, for your excellent presentation.